Um, my name is Sharon Day. I'm the Executive Director of the Indigenous Peoples Task Force. Most people know me by that name, but my spirit name, my ceremonial name is Nagamomaingan, which means Semimo. Thank you.
Miigwech, thank you. And Dr. Stately, would you please introduce yourself?
Sure. Good morning, everyone. Good afternoon. I'm Antony Stately. I'm the Executive Officer of the Native American Community Clinic and Ojibwe and Oneida. And I have a spirit name too, but I'm not going to tell you what it is. Joking. It's Ogabishkang. It means I can't tell you what it means. It's the meaning is too complex. So.
Thank you, Miigwech. Michelle?
Hi, everybody. I'm Michelle Corcoran. I am the nurse manager for the MAT program at NACC. Thanks for joining us.
Thank you, Miigwech. And Nikki?
Hi, I'm Nikki Jardina, and I am the infectious disease nurse care coordinator at NACC.
Miigwech, thank you. And Tina?
Hi, my name is Tina. I'm the HIV case manager here at NACC.
Thank you. And I'm Kari Rabi. I'm a family practice and addiction medicine physician here at NACC. I'm working largely in the MAT program. Okay, so if we can start the slides, please. Thank you. All right, and today we've done our prayer and land acknowledgement. We did our introductions, so I'm going to go through the agenda now. It's a special Midwest Tribal Echo today because it's World AIDS Day. So that's why we're excited to have our speakers today, Dr. Stately and Sharon Day. I'm going to go through Zoom guidelines, and Tina's going to do the announcements, and then Dr. Stately and Sharon are going to do the didactic. We're not doing a case presentation today, and then we'll close. So please let us know who you are. You can introduce yourself in the chat function, your name, title, organization, and email. You can also update your name on the screen by right-clicking and renaming yourself. Please turn your camera on so we can see you. It's so much easier to do this when we can see each other, especially for the speakers. Please mute your microphone when you're not speaking. If there's noise coming from your direction, we may mute you. Please don't be offended. You can use the chat or hand raise function if you need attention, and then please no protected health information on this format. Tina, would you do the announcements?
So just as a reminder, this echo meets every first and third Wednesday of the month from noon to 1 p.m. Upcoming sessions are on December 15th, China Pfeiffer from NACC and Dr. Ryan Kelly from COOP will be talking about their work doing outreach in hospitals with people who have endocarditis. And then on January 5th, Dr. Stately will be back on with us to talk about historical trauma. So we're part of an overarching series called the Opioid Use Disorder Education and Treatment Echo. That's with Stratus Health, and so under them there's another echo that Dr. Heather Bell and Kurt Devine run, and so that happens the first and third Tuesdays of each month from 12:15 to 1:15. If you want some more information about that, you can reach out to me. Case presentations. So the format of the echo usually includes case presentations, and those are a good time for us to bring sort of like real life situations to the table so that we can all talk about clinical issues with patients that we're working with. Anyone can submit a case presentation so that we can talk about it. If you're interested in bringing a case to the table for discussion, please reach out to me and I can send you the link for the survey that I'll have you fill out. But as Dr. Rabi said, there's no case presentation today. For continuing education, I'm not sure if we're going to be offering it today. I will have to check in with Stratus about that. If you are interested, please reach out to me. Usually what happens is for the physician credit, I send out a survey after the echo, and then you just complete that. But again, as I said, I'm not quite sure if that's going to happen today. And then also, if you all could just introduce yourselves in the chat, that would be greatly appreciated, just with your name, where you're from, just for our records and just to introduce yourself. So I'm going to stop sharing now and hand it over to our speakers. And then, yeah, I think at 12:30, I'm going to just give a little time check, and then let me know, Sharon and Dr. Stately, when you need me to share slides again.
Sounds good. Sharon, you're going to go first because you have a board meeting. I'm going to make sure you have ample time, so be thoughtful about your calendar.
Thank you. Dr. Stately asked me if I would talk a little bit about Indigenous Peoples Task Force and how we began. And so back in 1987, which is probably before, I'm trying to look at the screen, maybe a couple of you were born. A couple of people came to me and said, I have HIV. And at that time I was working for the state of Minnesota for the Department of Human Services and the Special Assistant Director for the Chemical Dependency Programs Division. And so one of those people was my brother, and another person was a woman by the name of Carol LaFavor. She was a nurse. And I had assisted with an intervention with her some years before that. And so, my brother was just, it's a big A, says, like, will you help me tell mom? But Carol was, what are you going to do about this? Because there are no services. And so there were a number of us got together. Joanne Stately, who was working at Indian Health Board at the time. Lee Staples currently lives at Mille Lacs and is one of their spiritual people. And I'm forgetting his name, but somebody who was at the Indian Center. He was the assistant director at the Indian Center at the time. And then Lori Watso, who was a student. She was a nurse and she was working on her master's in public health. And so we got together and we began to think about what should we do. And so we organized, we hired Lori to do a curriculum, and she went around the state and educated people. And at that point, we assumed that somebody would pick up the work, but nobody did. And after a year and a half, then we formed what was then the Minnesota American Indian AIDS Task Force. And we did a little bit of outreach in the beginning, and then immediately began doing case management services. And, we've branched out since then. We changed our name to the Indigenous Peoples Task Force in 2000, and we began working on tobacco prevention. We also had a charter school that was an art and wellness school curriculum. And we branched out into other areas. But about a third of our services still are focused on HIV. And we're funded by the Centers for Disease Control. And we also have some other grants that deal with Narcan training to community people, distribution, syringe exchange, and case management, both medical case management and non-medical benefits counseling. In 1993, I think, one of our case managers invited me to go visit a woman who lived over on 11th Street. And her name was Jackie. And she was a Native woman from Standing Rock. She had 6 children. And the house she was living in, the back door was boarded shut. And the landlord really used the basement as just kind of a dumping ground. And at that time, the vacancy rate for apartments was only about 2% in Minneapolis. So virtually there were no vacancies. And we decided to increase the housing stock. And so we raised money and we built our housing complex over here on 23rd. And so we have 14 units of affordable housing. And we've been providing that since 1998. The units range from efficiencies, which are about 500 square feet, to 4-bedroom units. And since, once HIV became more of a chronic disease, then we also made the units for people with a disability. So it doesn't matter what the disability is. It might be alcoholism or addiction, or it could be like a physical disability. So the housing units are now for anybody with a disability, but there's still a number of people with HIV living in our units. And when we built the units, nobody wanted us here. Every neighborhood we went to with land, in Minneapolis, you have to go to a housing council, community council. And every council we went to, they said, oh, there's some land over here, maybe you should go check that out. When we found this land here, we said, this is it. And so, and again, it was the same kind of thing, maybe you should look over here. Nobody really wanted us, because at that time, HIV still has some stigma attached to it, but then it was even more. And I think a nurse from the health department actually went door to door to educate the community, people living in the houses, that their children weren't going to get HIV from playing with our children in the units. And we stood our ground, and eventually built this housing. They're beautiful units, and they're still beautiful inside and outside today. Very organic living space, no carpet, so they have radiant floor heating, which is very good for people with respiratory problems. And we were the first organization in the country to develop a brochure for lesbians. In fact, our first 2 clients were Native women who were lesbians, and we decided that we were going to deal with people didn't want to deal with HIV issues because of not only the stigma of, and back in those days, if you had there wasn't such a thing as AIDS, it was HIV, you had AIDS and you were going to die. And so people didn't want to deal with, with that. And the other part of it is because, and still today, the largest percentage of people living with HIV are Two-Spirit men. And so the board decided, and I, that we were going to deal with this issue of homophobia, like right up front. So whenever we're going out to do a public education, we talked about it. Otherwise, people were just like sitting, waiting for like, oh, what are they going to talk about? They can talk about that, and like waiting for the other shoe to drop. So we incorporated that into we hired a Native artist from Lower Sioux to develop posters. And so, they were coded a little bit, but people who needed to know and knew what they were. And they were targeted at again, there still even wasn't the term Two-Spirit, they were targeted at gay men. So that's the way we've always sort of approached our work, directly, up front, and dealing with those issues. And I think, at the task force, we've always dealt with some of the issues that other people didn't want to. HIV, we started doing our work around tobacco prevention. 66% of the adult Native population were smoking. Like who wanted to deal with that? So today, we have this outbreak. The numbers went down over the years. And then within the last several years, we have this outbreak here in the Twin Cities and also in Duluth. And you probably all know that better than me. And coupled with that, the other issue that we're dealing with is COVID and opioids. So, Native people are 7 times more likely to die of an overdose than the general population. And in terms of the numbers, Native people, it's 0.169%, 1.169 per 100,000, compared to a rate of 0.10 for white folks in terms of opioids. So we have COVID, we have this large number of unsheltered population, and you have this addiction, and dealing with fentanyl that is far more potent than people. There's done the I always think, like, people who are making these drugs, they don't really want to kill off their customers, right? But they also have no way of like dealing with how potent, how much can they use, and so you have increase in everything that goes along with addiction and poverty. You have trafficking, and there's not a person in the Native community that isn't affected by this epidemic. And just a couple of weeks ago, I had a grandson who died from an overdose. And, to our knowledge, he was not he liked to drink. We never knew him to use drugs. Somebody gave him something and, he's gone. And so, there isn't anybody in our community who hasn't been affected by this. And so, we have to double down, triple down all of our resources, all of our services to deal with these, these three, people don't get HIV easily. You have to do something in order to get it. And who would have thought that, when we first were getting involved with HIV, that, here we are all these years later, still no cure, although there's medication. That's what we have to get people is PrEP, BEP, and MAT services, and then ultimately get people into treatment, because it's not enough to just treat the symptoms of addiction. We really have to get at what is the reason. I myself am in recovery, 46 years, something like that. And you get this old who counts anymore, like, but I've been in recovery since I was 23. And, we need to get to not just dealing with the symptoms, but really what are the underlying causes of addiction? How can we help people heal from that? And I'll stop here and turn it over to Antony. Thank you very much.
Chimigwich, Sharon, my thoughts and prayers to you and your family. I know it's a hard loss for you on the death of your grandson. An amazing talk, so thank you very much. And Chimigwich for all the work that you have done over the last 40 years, and also the work of IPTF, fundamentally being the soul. For a really long time, you were the sole organization doing that work in Minneapolis and St. Paul, across the state really, for Native people struggling with HIV. So I've been a leader for a long time, and I really appreciate that. I'm here to talk a little bit about my own personal experience of being a Native man, Two-Spirit man, living with HIV. So I've been living with HIV for it's getting close to 31 years. So February of 2001, 1991, sorry. Trying to do the math in my head. I'm not old, yeah, I'm 59. So I was diagnosed with HIV when I was 25. And at the time I was, it was shortly after I had left Minnesota and moved to the West Coast, to Los Angeles. So I kind of ended up, moving to the West Coast when I was a young man at 23. And, I kind of landed on the West Coast in Los Angeles right as the pandemic or the HIV epidemic sort of was kind of exploding, right? Here in Minnesota in 1984, 85-ish, we're just kind of sort of like, we were hearing about this stuff going on, but you didn't really sort of, it really wasn't very predominant in the community here yet at that time. So I think, operated from the feeling in the sense that I was a little protected, right? And everybody that was dying from, in the news were like, gay white men. So I thought I was fairly safe. But I left here in Minnesota, moved to the West Coast because I was struggling with addiction myself for most of my adolescence and my early adulthood. I think I started drinking and using drugs at the age of 11. And so my first attempts to get clean and sober were around the time I was 16 or 17, my first year of college, 17. And I wasn't able to accomplish that until I turned 23, just after my 23rd birthday. And shortly thereafter, I moved to Los Angeles when I was about 4 months sober. And I left here and moved there mostly because every single person I knew in my social network used drugs or drank. Almost everybody in my family drank. I didn't really know a whole lot of people who were clean and sober. I didn't know Sharon at the time. I knew relatives or friends with many of her family members, but I didn't know her personally, and I didn't have a lot of other people, in my sort of like personal view that were Native and were clean. And so that was, so my perspective was like, all the gay folks I hang out with downtown, they all shot drugs, and I was just starting that behavior when I got clean, and I ran as quickly as I could from here because I knew that if I stayed, I would die, right? So I was like, oh, I gotta go. So, and so I stayed on the West Coast for a really long time, and I didn't return back here to Minnesota until 12 years ago when 2 years after my sons were born. And I too been clean and sober for about, I think I'm at 36 years now. October of 85 is when I got clean. It was really a challenge for me that I became HIV positive early in my recovery, right? And it was hard for me and very stigmatizing for me to sort of kind of come forward with that information. I kept it from my family for a really long time, mostly because I was afraid to hurt them. I knew that it would be really tough for them, for me living on the West Coast and them to be living here. And then the other part of that I was living out in Los Angeles, and even though they have a very large Native population in Los Angeles, they're just, unlike Minnesota, they're dispersed all over the place, right? And so I didn't see a lot of Indians. I saw a lot of brown people that like me, but they all were Native. We're all Latino. the first, I would say 5 or 6 years of living with HIV, I just kind of, you know, like stayed nice and tightly in my little closet around HIV, except within my own specific community in Los Angeles. And it really wasn't until I became like a psychologist. I went back to graduate school. I went to graduate school and became a psychologist because this is, you know, I was a young man at the time. I was 28 years old, 29 years old. And I got my diagnosis in my last year of college. And then I was like, oh, okay, well, if I'm going to die, I'm going to die a doctor. That's what I put it on my tombstone, Dr. Antony Stately. So I took out lots of student loans, which I'm just going to pay off until I die, practically, actually. But the point being is like, you know, it wasn't really until I sort of kind of got into my work as a psychologist, and also my work as a researcher and also as a clinician, that I kind of began to sort of understand my own experience, like, and my trajectory of risk, as they like to call it in research. You know, like, oh, let's try to understand people's trajectory of risk, right? So it really was only after I had that experience where I was able to sort of look back and reflect on like the things that were going on in my life, the things that led me to where I was, and then also the things that were going on in my life at the time, that sort of placed me in a position of being at significantly greater risk because of a lot of things that were outside of my own personal control. Right. And in healthcare, we talk a lot about self-efficacy. We talk a lot about like, you know, personal agency and all these other things. And we talk about those things as though those things are supposed to protect us as individuals. Right. And here I was, you know, I've had a lot of therapy around this, so I don't really break down and cry anymore about this, but here I was a 29-year-old gay two-spirit Native man living in one of the largest cities in the United States, not connected to any Native people at all, but in my early recovery, in a relationship with a much older gay white male who was HIV positive, and you know, working at some little rinky-dink, you know, $7 an hour job back then, right? And trying to sort of like get an education and pull my life together. And then concomitantly at that same time, everybody around me, every single person around me in my social life, the people that I had developed relationships in AA and in the gay community, were dropping like weekly, like flies. Like, you know, if they get sick, tell me they're sick. A couple weeks later, they're dying. You know, in between the years of 1985 and 1992, 93, when sort of kind of like heart came, you know, some of the more effective medications came out, I buried, you know, several hundred people that I loved dearly, right? And within that context, I also happened to be like a Native kid from South Minneapolis, right? Whose life experience kind of, you know, in many ways mirrors the kinds of life conditions that many of our shared patients have, like those of us who work in South Minneapolis with the homeless folks. You know, there were many, many times when my mother, who was a victim of domestic violence and a bunch of other things, were like always on the run, sleeping at other people's homes, those kinds of things. That's kind of like the context in which I grew up, right? And I had, you know, violence and, you know, I also was a boarding school survivor, so I had a lot of sexual abuse that I survived as a result of that. A lot of, and you know, prior to 1985, I had no therapy for any of that, right? That wasn't something we talked about. So I also didn't have a lot of access to traditional healing. I lived in South Minneapolis, you know, and I didn't, you know, we didn't get to go back to our home res a whole lot. So as I sit and I reflect back on my own history, on my own experience, it's actually a miracle and a blessing and a godsend that I'm still alive, right? I had plenty of other people who I used with, who were also two-spirited, who did not make it, right? And it's on World AIDS Day, I always sit and reflect on this. I reflect on like how blessed I am, but I also reflect on the people that are no longer with me, who, in some ways it was also just like really, I think one of the hardest parts was like, how in some ways it's kind of ironic. I was just thinking about this yesterday as I was trying to formulate my thoughts for my talk. And I was like, it's a lot like COVID, right? It's like, it kind of feels like this thing is just sort of like it helicopters in and, this person gets sick and gets well. And I actually had that experience last year. And on this, and somebody over here gets sick and they don't do well and they get sick and they succumb to it, right? And that was kind of also my own experience with HIV. It's like my friends, we all sort of kind of like, I have 2 or 3, 4 or 5 friends that I gotten sober with early on. We kind of all got HIV around the same time, and 4 of those people didn't survive, right? So that those are kinds of things like you try to make sense of those things, right, in your life. And so I was struggling out there as a young man trying to make sense of all of that stuff. I think the beauty, so I have the opportunity now to look back and say, oh, okay, well, what did all of those things teach me? I think those things taught me a lot of that lived experience enriches the way in which I think I show up in the work that I do, and how I think about in the role of this of being the leader of this specific organization, why it's really critical for us to be sort of like, building out infectious disease services within the context of MAT and OUD services, right? Like we can see the confluence of these things together. Early on in my research career, I was at this, fancy research career. I think it was at the U.S. Mayor's Conference on AIDS. I think they still have that every single year. And I was living in Los Angeles at the time, and I was doing a lot of the same kind of work that I'm doing now, except in a different context. I was working for AIDS Project Los Angeles at the time, the second largest AIDS service organization in the United States, and I was trying to advocate inside that big, huge organization, the critical need to develop HIV services for Native people back in 1996, 97, 99, when I was sort of still living in Los Angeles. Because even then, almost 30 years ago, we were significantly overrepresented in the numbers of HIV per case rate data, right? And so as I stand here 31 years later, myself, a survivor of HIV and a survivor of all these other things, and here we are, we're in the middle of this endemic of homelessness, opiate use disorder, HIV, plenty of other infectious diseases that go along with that, hepatitis C and a bunch of other things where we're crazily overrepresented in those things. I stand here and I think, it's been 30, 40 years and things don't feel like they necessarily got better. The scenery's changed, but nothing much has really changed. And so that's like Sharon, I feel a sense of urgency, right? And I feel a sense of, I personally, within my own personal role, but my professional role, feels a sense of urgency to double down, triple down, quadruple down on this work, right? Because we are losing so many of our relatives from these things that are completely preventable, right? All of this is preventable, and that's the hardest part of this whole entire pill to swallow, quite frankly. And so, a couple of years ago, I worked with my chief medical officer, Dr. Kari Rabi, who's one of the faculty on the ECHO, and we talked about, becoming an HIV center of excellence. let's start to do this work, because we would get patients coming into the clinic who would test positive and who would have all these other things that were going on. Maybe the HIV positive and also hepatitis C positive, and they didn't want to go to like HCMC or other places to get care because they just felt stigmatized, highly stigmatized. They walk into those places and they feel like, oh, people look at them and treat them like, oh, you're just another drug user, you're just another this, you're just another that, right? And I remember feeling that sense of shame and that sense of stigma and that sense of what it felt like to carry that burden. And I have so many more resources than a lot of our relatives, and I still at times feel that way. So I'm in the position of being able to say, like, we're going to do this work because no one else is doing it, and we have to do it. We have to find a way to make care more accessible to our people in a space and an environment where they are comfortable and they feel like that place is like a safe haven to them. And so partnering with organizations like IPTF and partnering with a number of the other people became a really critical point for us as an organization to start to do this work. Partnering with NACC on a HIV transformation service transformation grant was really critical. Those are all things that have been really important. And this team that we've assembled at NACC that does street outreach and HIV care and prevention has been really an amazing group of individuals. And so I wanted them to talk a little bit about the services that we have. And I know we've prepared these really amazing slides that talk about rates and and all those things. And I think that's less important in this conversation, quite frankly. I don't know how many people want to look at the horrible rates of HIV and hepatitis C and opiate use disorder. And I mean, if there's anybody on this echo that doesn't know that Native Americans are the highest rate of practically anything that you can measure in the state of Minnesota, except for wealth, you might have been living under a rock for the last couple of years. So I don't know that we necessarily need to go over those charts, but I think what's really important here maybe is for us to talk about the work that we do and how we do it, and let people ask questions about that. So with that, I'm going to let the HIV folks, Tina and Nikki and Dr. Robbie, talk about the work we do.
Sure, I can kind of lead us into that. Thank you, Sharon and Dr. Stately, for talking and sharing your experience. I'm Tina. I'm the non-medical HIV case manager at NACC. I've been at NACC for almost 3 years, but in June, I was hired into this role. And so my role essentially is to help the people who are testing positive and even people who've already tested positive, just to kind of access care here at the clinic or any other clinic of their choosing, and then also to access social service supports, because in Minnesota, as many of you know, there are like specific social service supports for people living with HIV, and then in addition to those, just any other supports that are available. And so some of the biggest things, well, the biggest one is housing, really. Every patient that I've been working with is facing some kind of barrier around stable housing, and then phones, and so like having those two things in place, so that people can find consistency in taking their meds. So yeah, those are the kinds of things that I work on, and really trying to create a program that is like meeting people where they're at, so that they can feel motivated to kind of take charge of their health, and like learn about how they can take charge of their health. And then, so that's sort of like the case management side of things. And we also have been doing for quite a few years now, like rapid HIV testing. And James Schmidt, who is on, I would say he really has been one of the leaders in bringing HIV testing to the clinic and getting people to be tested and not only doing HIV testing, but wrapping harm reduction services into it. So offering syringe services and bus tokens and food and snacks, and just generally being someone acting as a bridge to the clinic, and being a trustworthy person. A lot of the people who do get tested, who we want to get tested, are people who have really long-standing, solid relationships with James and the rest of the outreach team. So yeah, outreach, case management, and then Nikki and Dr. Robbie do the stuff on the medical side of things.
Yeah, so so we have I think we have a very collaborative kind of relationship between the medical side and the outreach care coordination side of our HIV care team. And so there's a lot of overlap, but sort of speaking from the more medical side, just really briefly, we try to bring all those same values and that Tina was just talking about into the medical care that we provide around HIV too, trying to be very harm reduction focused, non-judgmental, respectful, client-centered, trying to really use our strong outreach to and our community-based rapid testing to facilitate warm linkages back into the clinic if that's what people want, not just for our own HIV testers, but also for HIV testers from other organizations if they have a new positive, or even know someone out in the community who is HIV positive and not currently linked to care. We like to try to get them in same day if we can, just to kind of reduce as many of those barriers as possible. So we try to offer walk-in appointments when we can, have really sort of non-stigmatizing language that we use with patients, speaking, frankly, without value judgment about drug use, about sexual activity, trying to offer people tools to use harm reduction practices, and also knowing that people are often the experts in their own health, and so we learn a lot from our patients too. And we try to offer care in as sort of non-hierarchical a way as possible. So by having this sort of horizontal care team, and then we invite the patient into that care team as part of it, rather than sort of seeing this as like a power-based dynamic. Some more kind of just specific things really quickly, we're offering financial incentives for HIV care now, actually. And so there've been some studies that have shown that that's worked. And so we're kind of piloting that, and we've gotten good feedback so far. So, we're doing same day antiretroviral therapy start. So somebody who tests positive for HIV today, or comes in knowing they're HIV positive and off meds, often we're able to get them started on therapy same day, or same day prep. Jace, our nurse manager, he has instituted like a same day prep protocol within our clinic that all of our medical providers can access. And we offer people all of the harm reduction supplies that we offer during outreach. We offer them during our medical appointments too. And our work with NACC has been extremely important and supportive in starting this program over the past several years. So we've been working with them since 2019, like Dr. Stately said, in our performance transformation project to our practice transformation project to become an HIV center of excellence. And they've just provided us with with amazing support and contacts. And now, you know, our medical team has contacts with infectious disease experts so that patients, if they feel most comfortable seeking care here, they can stay with us, but we can access those years of knowledge that longtime HIV providers have elsewhere. So, so yeah, I don't know, Dr. Robbie, if you want to add anything.
Just that I think that the collaborative approach, like having a team of people and utilizing everybody on the team, it makes such a big difference. And for, you know, we have 6 providers at NACC, and we're doing primary care, and we're doing a lot of different things. And so really utilizing nursing to the top of their license, so our nurses become subject matter experts in things like HIV, hepatitis C, opioid use disorder. So they actually act as they can a lot of times be reservoirs of knowledge for the providers. If it's a provider who hasn't, for example, you know, for doing the PrEP or hepatitis C, providers actually access the knowledge from the nursing. And I think that having the Suboxone program and the MAT and co-location of services, as well as having a dosing clinic and having IOP available for our patients, having all those wraparound services, kind of so really convenient for the patients, for the things that are the hard, for the most marginalized and vulnerable of the patients, that it's really difficult for them to access and to go elsewhere to try and make that available, I think is very important. But again, I can't emphasize how great it is to have such an amazing team of people working and collaborating together to provide this care, and then to see the patients as a part of that team, and you know, being the one making the decisions about what they want to do with their health, but providing them with information and resources. Yeah. So, before we have like
open it up for questions, I guess.
yes, exactly. Thank you, Dr. Stately.
I was thinking, Nikki or Tina. I don't see Tina. I'm sure she's here. I just can't see her. Maybe you can put the slides in the chat, and people can still see the information if they really want the information. But I don't think we have time.
Yeah, or we could email the slides out too, maybe.
Yeah.
I think Tina has
a
the
good idea.
capacity to.
Yeah, I'll do that.
Sounds good.
Thank you.
I was just thinking maybe Christy, and we might need to do that technically for CME credits or something, give them some actual hard data. So I don't know.
So as we wrap up, we have about 5 more minutes. Anybody have their own experiences around this, or have any questions for us?
I actually need to jump off in a couple of minutes for a call I'm hosting, which you're all invited to attend. It's the NIDA Clinical Trials Network, American Indian Alaska Native Special Interest Group. But you know, I work primarily with Hennepin Healthcare Research, as many of you know, and I'm just curious. You know, I've been there for 3 years, almost 4 years, and the question keeps coming up from folks at Hennepin, and of whom, you know, Dr. Tom White, others are Native American, you know, how can we do better outreach and partner better with the organizations doing this well? And I think in the last year or so, I hear like a lot more collaboration going on. I hear the services and programs sort of being built up more so at NACC. But I'm just curious, like, well, what is your experience and with working with Hennepin Healthcare, the addiction consultation service? And then one of the questions Dr. Wyatt always has is, for me, Paulette, what can we do when people come into the emergency room and they leave? It's just rotating door. And, you know, Dr. Wyatt especially wants to be more helpful for our people. I'm just curious if you guys, you know, what is that relationship? And unfortunately, I'll probably have to jump off soon. I'm just curious how that works, or your experience, or if you have any advice.
I hope just to speak as frankly as I can, as I think I can. I think that the thing that I've noticed with Hennepin is it can be siloed. So like we have a great relationship with the addiction medicine department at Hennepin, and we've met with Dr. White, and he's been very, very interested in working with us and helping us in what we're doing. But it seems like there's some siloing of departments, and so where things need to flow across the departments. And I think that's obviously a difficult thing to address in a large organization. But it seems like sometimes people aren't empowered to make the decisions to make those large movements. I do know that when our outreach team is out and doing work, we work with Healthcare for the Homeless, which I think is a Hennepin affiliated or Hennepin organization. And so we work with them and Southside Harm Reduction Services and our outreach team. They kind of converge together on spots and collaborate and work together. So I think that in that sense, they're doing a really good job. And then I also know that our peer recovery coach, China, has worked with patients at Hennepin who have specific needs I can't think of a specific example right now. Perhaps it's not appropriate to have a specific example, but in the general, we've had patients, for example, with endocarditis or other sort of chronic conditions, and China's been able to connect them with services, and also we've been able to connect patients with elders and spiritual care that are at Hennepin. And I don't think that Hennepin has utilized that as much as, for example, Fairview System.
No, they have not, and I need to jump off, and I would love to have more discussion around that because I actually had recommended that we utilize those services from the outside. So Antony, I don't know, maybe someone on your team we can talk to relatively soon. Yeah. I need to jump off for that call. You're all more than welcome to jump on, but thank you. This was excellent.
Thanks, Paulette.
Miigwech.
Thanks, Paulette.
You're welcome.
Okay.
Any other questions, comments? Yeah. That was very diplomatic, by the way, there, Kari. Good job.
I thought so. Well, thank you all so much for joining us. Tina, what's our next echo?
Our next echo is on December 15th, and China Pfeiffer from NACC and Dr. Kelly from Kook are going to be presenting about their outreach.
Peer recovery. Yep.
Yep, peer recovery stuff. So thank you, everyone.
Thank you, Miigwech. Thanks for joining us.
Namia, Wopida, Miigwech.